Thank you both for joining us on the podcast today. I appreciate it so much.
My pleasure.
You're welcome.
Awesome. So let's go ahead and we're just going to jump right in. Just for those who really aren't familiar with dental sleep medicine, can we talk a little bit about, what this is and how this is different from traditional dentistry?
Dental sleep medicine is a relatively new area of dental practice to us in UK. It's the discipline concerned with the study of oral and maxillofacial causes and consequences of sleep-related problems, which sounds very complicated. But
it does.
But it means we're assessing the airway, the space at the back of the mouth for airways, and to treat it, if appropriate, with an oral appliance. So if you have an airway with some obstruction, it causes sleep fragmentation. And depending on its severity, it can just be a simple snore to something more complex of complete obstruction. And the name given to the group of airway dysfunction that we have is sleep disordered breathing. And it's characterized by snoring and an increased effort to get breath.
So how would a patient end up in your office? Are they referred, or do you do traditional dentistry and sleep? How do they end up there?
I do both. And now we incorporate questions in our routine medical history. Do you snore? Does it bother you? Does it bother your partner? And then we are in a perfect place, because we see patients with their medical history coming in and their comorbidities, to just listen and chat and then assess what's going on in their mouth and airway. Because there's a lot of signs we can see that shows that they may be at increased risk of having this sleep disordered breathing from a young age up to adults. And it isn't a static condition, so somebody can start with snoring and it can progress to something further. Right. But snoring has been considered in the past just irritating noise, and now we are much more aware of the importance and significance to health and development.
And I would add, I know that we used to think it was cute. I did, even with my children, when they would snore when they were asleep. Oh, aren't they cute? Listen to the little tiny snore. But it's incredibly detrimental to children as well.
It really is. And snoring, as we said, is a sign of restricted oxygen. And not many of us would like to consider our children having restricted oxygen.
No.
No. They behave in a very different way. So for adults, you get a lot of medical issues. And in children, you get a lot of behavioral issues. So I don't know how much your listeners know about the physical effects of sleep apnea in an adult, and the long-term effects, or whether this is just about children, and where would you like us to go?
Well, we focus on children. However, one of the things that I think is an important concept to make sure that we hammer home to parents is why it's so critically important to take care of this in children, because of the effects that it can have in adults. So I'd love to just kind of veer off into that for a few moments to talk about, how this can manifest and the health implications that happen in adults.
Aoife, should I do this bit and you do children?
Yeah, let's do that.
Okay. It can be as acute as a bad night's sleep. In layman's terms, we all feel worse. We're tired, we're groggy, we're hungry, we're irritable. But actually, the continual lack of oxygen initiates loads of systems to go into high alert, and a chain of reactions to many body systems. It prevents you from going into a deeper reparative stage of sleep. But physically, the effects of apnea really affect the sympathetic nerve system into this fright or flight, complete stress all through the night and repeatedly. And that can affect every system, from hypertension and cardiovascular systems to metabolic and insulin resistance, to it can affect your immunity. It can affect the rate of cancer of some sorts, Alzheimer's, atherosclerosis. It's huge. The chronic effects are the diabetics. There's so many more diabetics who have apnea. In fact, most of them, 2/3, I think it is, have some form of apnea. So
Oh, wow.
really, it's a huge implication, and a lot of days are lost, monetary, work-wise, health-wise, and that's only to the person who's snoring. The person next to them is pretty disturbed a lot of the time, and it can really
Right. It can impact them. And it's two of the things you mentioned. Well, I mean, there's several, but two in particular, I think are not ones that as laymen we would automatically go to and think, oh, sleep apnea can lead to this. Cancer and Alzheimer's.
So those are recent things that have just come out, that really that complete stress reaction of your sympathetic nervous system can affect so many things, and the immunity and the inflammatory response and everything is put into this stressful, increased, high alert state. And they've been shown to be linked to both of those.
Wow.
And another one I'd add is the rates of sleep disorder breathing in pregnancy are often increased. A little bit more weight carried, a lot more stress in the body, and also some lack of less good quality sleep in general because of discomforts. And the effects on babies is quite interesting in mums who have sleep disorder breathing. So it tends to be a cycle that will then continue. So yeah, it's really quite interesting, and I mean it's quite early in research in that field, but certainly there are ways of kind of there are some case reports at the moment of treatment for women who develop sleep apnea during pregnancy, and treating it. And I think that's a really, really important piece, because if mom isn't breathing well, reduced oxygen to baby, and the effects potentially on the development of baby is really interesting. I think that's a piece that we will be visiting in the future. I think hopefully it'll be a case that all women who are pregnant at a certain point would have a sleep test, because I think it's a relevant piece to the next generation being healthier.
I think it's hugely relevant, and it's not something that we talk about much at all, which is sad. And you go through all of these pregnancy classes and they teach you all these things, but at no point does anybody say, hey, how are you sleeping?
I think in general, the link of different health issues isn't always related. I'm only talking about from Britain, that it's come new that the link of different symptoms such as hypertension and acid reflux and tiredness and headaches and all things like that could be suggestive of an increased risk of apnea. The medics haven't been taught that. We as dentists are just teaching about that, and it's really important.
It's usually and that's part of why we're here. And I think I say it on every podcast to parents as well as medical professionals. You don't know what you don't know. You weren't taught. We didn't learn this when we were growing up either. So we're all kind of in the same boat trying to learn together. Yeah. So that's something very important to remind ourselves. And I probably, if you don't mind, I'm going to want to circle back, because you mentioned, and it's not something we've talked about much on the podcast, pregnancy and sleep apnea and the impact it can have not only on the mother, but on baby. Mm-hmm. I'm going to just kind of guess, some of the impacts are definitely stress related to the child. So could the child develop sleep or breathing issues? Could it cause the child to have higher blood pressure, impact their development? What kinds of things are we seeing so far?
Well, I would expect, so those two biggies really would be the hypertension and the diabetes risk, because both of those we know physiologically are two major effects of having apneas. So I think it would be really interesting to see where, I mean, it's not something that I've come across in the research. It's just a few colleagues have done kind of case reports on pregnant women. But I think it would be really interesting to see, because we know that if you're having desaturations, that your body becomes more stressed. We know that that stress is going to raise the cortisol. We know that cortisol is going to wreak havoc with the blood sugars. So, you know, absolutely, there are women who develop gestational diabetes who have, you know, who are just having all the Coca-Cola, but there are plenty that aren't. And, you know, if you were to look at them from an oral and a functional perspective, I think it'd be interesting to see how they're breathing. And how that
Absolutely.
can impact food. There's a beautiful study that someone ought to do. Perhaps myself and Joe will buddy together at some stage.
Okay.
But you know, and these are things that I guess we're just not considering right now. And then the other one is we know that if we have the more apnea you have, the more likelihood you have of hypertension. And we know that hypertension in pregnancy can cause preeclampsia, which can cause early birth. You know, a lot of the kids in NICU will be because of preeclampsia mums, and you know, we have to consider, well, why. Absolutely, the pressure of pregnancy is going to possibly increase the blood pressure, but is it
Or
an apnea issue? You know, I don't think it's been linked yet, but or confirmed in research, but there's a good hypothesis there, I feel.
it's huge. Absolutely. So
In general, sorry.
yeah. No,
In
go
general,
ahead.
those people with apnea are 5 times as likely to have drug-resistant hypertension and double the rate of someone having diabetes, stroke, and congestive heart failure of those without disordered breathing. Now, those are 2 facts I come back to each time and think, God, why aren't we more aware of this? Because those 2 statements are huge.
Yes, they are. They really are. 5 times. So one of the things I have found over the course of doing this and speaking with other medical professionals is there was some kind of catalyst that transitioned you into sleep and airway. You know, doesn't seem like most people came out of, you know, medical school with this focus. So what was it for each of you?
With mine was the fact that I've been with my husband now for 35 years, and I used to just beg him to let me get, please, just give me 10 minutes, I'll be asleep. And everything was fine until one night I woke up and I was a good sleeper and I didn't used to wake, and I heard this foghorn next to me. And I thought, I'm going to kill you if you don't stop snoring. And then he stopped snoring. And for one little moment, I thought, oh, I'm powerful. I've just killed him. Oh, my God, I'm evil. And then he started to snort and gasp and breathed again. And it's terrifying to lie next to somebody and not hear them breathe. And I actually woke him the next morning, and he's a medic, and said, are you aware this is what happened? I even quite horribly recorded him to say, this is what you sounded like. And this is about 15 years ago. And then I started to look into it, and I made him a little prototype of some impression material in his mouth, and that used to fall out. And now we have gone to bespoke, beautiful appliances. And now, beforehand, the guys on the ski trip, nobody wanted to share a room with him. They said, nice guy when you're awake, but when you're asleep, it's hideous. And the guy who drew the short straw this year, he hasn't been for a few years, signed him off as absolute delight. No noise whatsoever. So, you know, when we can get great treatment outcomes, but that's what lit my fire. And now it's fantastic to make people feel better, to improve the quality of our patients' life. and you see people come back with their mojo, and you're reducing their risks
Mm.
of significant disease.
So even if you catch it later in life, you can have an impact on their overall health span.
You can, it's been shown that you can slow down the rates of things. It depends what we're talking about, and I'm not sure how much studies have been in. A lot of more studies have been done about CPAP and the reduction in risks. And now, as we're introducing our oral appliances, we hope they're the same effects. But again, there's another study.
Yeah. Oh, wow. And what about you, Dr. Stack?
So when I was, oh dear, have I lost you guys?
No, we're here.
See me. So when I was at university, my final year case was my father. And I, took him from, a mouth that hadn't been worked on in a long time, and I saw him like 20 times, and we fixed him right up goodo, and I got my honor degree, and all was well. And 4 years later, my dad passed away very suddenly. And it just puzzled me as to what on earth was going on, which made me, think about all of the potential symptoms. It really put me down on a rabbit hole. I was really keen to work out why my dad just was there 1 minute and not anymore.
Mm-hmm.
So then I kind of looked at all the images and pictures I had of his mouth and realized that he constantly mouth breathed. He had a narrow palate. He had worn teeth. He had a high malampati. He would wake up several times during the night.
Gosh, just the checklist.
The checklist, yeah.
Wow.
And that obviously is very personal and hard, but I would not want that to happen to anybody else's father. And that is why I am so passionate about trying to make change and trying to influence some difference, because lives can be shortened, and that causes pain all around. And if it's not necessarily shortened, you can live with a lot of comorbidities that are unpleasant and just give you less life quality. And we are very quick to look at pharmacological treatments for different conditions, but fundamentally, you sleep well, you eat well, you move well, you breathe well. Those pillars are going to lead to a better life. And it's amazing to have within my own profession to have the ability to make a change. So that is why I like working in this area, which is that's it.
And that's something that I do find that anyone that has done the research, first of all, there's something that gets them here. They don't just stumble upon it. Usually there's something, and there's this passion. Once you see it, once you understand it, and you realize, as you said, it's not just how it would impact your health span, it's your quality of life. And it's something so simple. I mean, it's relatively simple by comparison to, having to live with diabetes or Alzheimer's or some of these other things that will come down the road because of it. It's so simple.
Mm-hmm.
So I saw something, I'm not sure how recently you posted this, but there was a link between snoring and mental health. And I really want to talk about this because the U.S. Surgeon General has indicated this is one of his big initiatives is mental health, specifically in children. And more studies have come out that, mouth breathing and sleep apnea, they're impacting children and their mental well-being, depression and anxiety, which is off the charts in the U.S. As well as globally, but specifically here. So can we talk a little bit about how sleep apnea does impact children and their mental health?
So snoring is the sound made when the tissues have a restricted airway. And there's a spectrum from a little bit of resistance to more until there's a complete blockage that can happen multiple times a night. And as we've said, that multiple times a night puts your body into stress, and your whole body's in this active stress situation, physically and mentally. And adults with sleep apnea often suffer from daytime sleepiness and long-term cardiovascular effects and diabetes. And the kids, whilst they might be storing that for later, are much more likely to have behavioral problems, cognitive problems, development and growth. They have poor memory and concentration. They have behavior which mimics ADHD. And in some studies, they've shown that there is an increased incidence of ADHD with mild and moderate. And it says that about 1 to 5% of children have obstructive sleep apnea, and it's commonly underdiagnosed. And it's, kids can play up. We all know that we're perhaps not as patient when we've had a bad night's sleep. But if that's chronic, then we become less alert, less cognitively able, we're less able to learn with our mood, alertness and performance. And we often have more rebelliousness, hyperactivity, impulsiveness. We have difficulty controlling emotions. And most teams anyway are just learning, or kids are learning to control the emotions. They don't need the extra hassle of reduced oxygen brings. There's interesting studies shown that often children have problems because of large adenoids or tonsils. And they've shown that there is a significant positive impact on behavioral problems such as inattention, hyperactivity, oppositional defiance, and conduct disorder after adenodonticolectomy. I find that mouthful. My teeth around.
Wow.
And the mean scores of ADHD and all the behavior issues decreased significantly after the surgery, to the extent that the parents weren't bothered about the behavior. Now, I don't think it ever goes back down to the baseline group, and you do have a high risk of it recurring, particularly if you've got a higher AHI, or you've got a high arch palate, or a Mallampati score of 2 to 4. That's the rating we give to the space and of a crowded or a pharynx at the back. There's more risk if they're male or over 7, if they've got allergic rhinitis or asthma, or if they're of African-American race. So, there are factors that do affect it, but on the whole, there was a significant increase in behavior.
You mentioned something that I if you can speak to it, males over 7. So why are they different?
Not quite sure. It could be that males have a longer soft palate. I'm not sure. Aoife, are you sure?
Well, I guess the cranium would have pretty much developed at that point. So just I'm not sure, but I'm just thinking so if the soft tissues haven't caught up with the hard tissues, then potentially that's why, because at that age we're kind of pretty much facially developed. There's 80% of our facial development's done by age 6, so there could be that to it, but I'm not entirely sure.
I'm not sure either. I don't know whether you're starting from a different place, either.
Yeah, just curious.
Just this one point that I think is quite mind-blowing as well. The brain constitutes only 2% of the whole body, but it uses up to 20% of the total metabolic oxygen. And it's thought that conditions that reduce the metabolic oxygen affect the brain and cause cognitive and neurobehavioral impairments.
Right. Now, we have seen that it can decrease a child's IQ up to 10 points.
Yeah.
Which is staggering.
It really
that's a huge number.
It's an extra thing to throw up a child who's learning how to regulate emotions and their way through
Right.
it anyway. It's an extra thing that we can do something about. And, you know, there's some things we can't do about, but
that is something we could. So,
it is.
so, you know, we've talked before about the Mallampati score, and I'll make sure to put, for those who haven't seen, I have a visual that really shows the four. So that they'll have a perspective of what we're talking about. How do you know, though, that, you know, just removing the tonsils, for example, would be enough? Or do you even have to go that route if you can look at a child's mouth and see, oh, they have no room? You know, where do you start?
It's a few things. I've got a picture here that is of a child's adenoid face. I don't know if you see that, with an elongated face, and you have venous pooling, and it looks a sort of different sort of face there. Often where they've got a high vaulted palate, narrow jaw, narrow face, and often their head is, if I show that, is forward. Their posture is of a head forward as they're trying to get more airway. So sometimes you see a child as they walk in. I think we might have lost Aoife.
I see that. Well, I'll watch for her to pop back in.
Okay. And so a child can often have dark bags under their eyes. And then you open the mouth and you see quite often worn teeth, because worn teeth and bruxism is often now thought to be a sign more related to some sleep disordered breathing.
Which is grinding your teeth, correct?
Yeah.
Okay.
So you often see that. And then the jaw, top jaw, typically we want it to sit outside the bottom jaw. And in a lot of these cases, you've got a mismatch and everything's very narrow and there's nowhere for the tongue to go except backwards. And when a child then lies down, the tongue goes back. They've already, if you open their mouth, you can sometimes see the tonsils kissing. And it's called kissing tonsils as they're meeting at the back. And the tonsils are the tissue at the back of the mouth, and the adenoids are the tissue at the back of the nose. And if you've got that inflamed tissue at the back of the nose and the throat, then you are hampering that child's ability to breathe.
So you could start there as you're trying to bring the jaw forward and make some of the other adjustments just for the immediate relief.
Well, I think at that point I would ask someone, you know, do they snore? Can we, you know, have you been to see an ENT? Opinion. Before I started playing, I would at that point refer on. I think it's appropriate, you know, that if there's a significant other problem, we try and get that long term. Right. And some children grow out of some of the adenoid chronic things and don't need surgery.
Okay, that's interesting, because this is now the second time I've heard this mentioned. How do you know when to do it, when not to do it? Because I've also heard something very similar about a tongue tie, which I was under the impression you always take those out, but apparently you don't always treat those.
I'll leave Aoife to talk tongue tie, but with the adenoids, I don't know, and you need an ENT consult.
Okay, got it. Got it.
With regard to the adenotonsillectomy, obviously, if we don't need to put a child through surgery, that's better.
Right.
But if the tissues are chronically damaged or chronically inflamed to the point that they're not going to come down, then, you know, I think it becomes a no-brainer if it reduces the breathing space. But children do grow out of tonsils and adenoids. They do tend to get smaller from the age of 6. And also the other thing is, you know, if there's allergies and there's a change to that exposure, then that can reduce the size of the tonsils. And the other thing is there has been the UNE study, which I'm sure you will have come across before, where expansion of the palate has led to reduced tonsil size, but more research is required.
Yes, more research. It's still, I mean, that's the other thing. It's still so I hate to use the word new, but it is. It's still so new, and there's still so much we don't know.
Yeah.
Yeah.
And it will take time for this to filter through to dentists, doctors, midwives, everybody involved in it, because it should be a multidisciplinary approach as well. But with increased awareness, hopefully parents become more aware, dentists become more aware, and we can all, there are, in Britain, hopefully there will be more myofunctional therapists to help, and we can start treating these patients in a conservative, preventive way.
Mm-hmm. Right. So we're getting to the root instead of let's just keep putting Band-Aids on it and let's just give them medication. And understood. So you mentioned myofunctional therapy, which was an excellent segue for my next question. So, Dr. Stack, let's talk a little bit about how myofunctional therapy plays into sleep hygiene as well as sleep apnea treatment.
Okay, so I would separate sleep hygiene and sleep apnea treatment. So sleep hygiene is things that we can all be doing to improve our sleep architecture.
Okay.
So the amount of deep sleep we're going to get, etc. So that's to do with how we live our lives on a day-to-day basis. So how we're eating, how far away from our night we're asleep, how far away from our night sleep we're eating, how well hydrated we are, what we've done in the hour or two before bed, light exposure, first morning light exposure, sunset exposure, our melatonin levels. It's pretty easy to get it right if you follow what we're supposed to do. And if you have a really easy life, that means that you can just go and look at the sunrise and go look at the sunset and take all your air outside and not be exposed to toxins, and eat all organic food, and have not have conversations late at night on computers and all those things. So
right, for the two people in the world that can do that. So for the rest of us, right?
I should have my blue blocking light goggles on. That would have been really impressive. Just wouldn't have looked so good. But yeah, so all those sorts of things would kind of fall under sleep hygiene. And then stress relief, breath work, all those, where we're looking at myofunctional therapy, we're looking more at actual targeted exercises to treat the or motor dysfunctions that we present with. So whether that is weak lip support causing, mouth breathing, whether it's a tongue that is a bit floppy, whether it's a tongue that quite doesn't fit into the roof of our mouth, whether it's a tongue tie, whether we have, TMJ problems because of poor chewing, whether we can chew at all, a host of issues. And those are structural and functional issues that need therapeutic support rather than being a case of, well, because we could have amazing myofunctional support, but if you decide to drink 3 bottles of wine before you go to bed, it's not going to make any difference.
Good.
Or similar, if a kid has, lots of Skittles before bed, so it's managing two different things, but it's for families, it's very much on mum and dad, or mum or dad or parents, whatever that looks like, to manage both hygiene and all the therapies and whatever else comes with that.
Everything together.
Yeah.
So for parents that are, and we've got a few things on our website, which I'll make sure we include a link to here, about what good sleep hygiene looks like. But for parents that are, just becoming aware and are overwhelmed, which is what we find a lot when parents, find out what's going on, what are a few things they could start with, that would be pretty impactful when it comes to sleep hygiene? Just, with a younger child, what are some things they could start with initially?
Screen time is a big one.
Overall, or just before bed?
overall, we all could do with less screen time.
Yeah.
You know, we weren't designed as humans to be in front of screens, so you know, that's a given. But certainly later on in the evening, certainly the less screen time, the better. You know, light exposure, having, you know, less blue light generally. You know, you can put dimmers in your light, you can have certain wattage on your lights. Lots of hydration, you know, not eating too close to bed, looking at your sugar kind of consumption throughout the day, um, breath work if it's possible. There's some simple buteyko breathing exercises that can be done that are quite
Yep.
nice. You know,
Relaxation.
trying to get the kids outside if you've got green space. You know, it's not easy, man. It's really not easy,
No, it's not.
but you know, at the weekends, making sure that there is outside activity. You know, just trying to live as naturally as possible is a good way to think this is the way we should be helping our sleep, because
Oh my
you know,
God.
we used to be able to sleep pretty well, and we now have so many toxins all around
Yeah.
us, along with all these toxic lights that are not good for us
Mhm.
either.
Right. And as a mother of at least one that's still in school that has everything on an iPad. Back in my day, we had the backpack with all the books, and the worst we had to worry about was throwing out a shoulder or a rib or something with a heavy backpack. I'll take that. But to see a child that has no books and they're constantly on their iPad, everything is on the iPad. The book is on there, the homework is on there, the lectures are on there. You know, it's one of those. I would just like to rally that. Please bring back the books. That's all I'm saying.
I think to have a time that stops that and then a transition of relaxation before a regular bedtime is at least something you can do. Aoife's right. If we could all get much more fresh air and all go back to whatever, but that is unlikely to happen when all your work is on your iPad.
Exactly. It is, right? And my heart goes out to the kids that were like me. They were doing homework late into the night, especially the teenagers. You have after school events, you have band, you have cheerleading, whatever, and you have a job, and then you come home and you're with your family, and then you're doing homework late into the night. You know, we're just basically handing these children health issues. So
Yeah, and it's
my
not
mom.
just children, you know, like it's throughout, you know, like I have a 5-month-old baby, like he's not really exposed to screens just yet, but that's going to come, and it's really interesting because I'm currently working through sleep learning, and like the pattern that we're that's known to work would be, you know, feed, then feed in a kitchen environment, like feed in the kitchen so that they get used to eating their last meal in the kitchen. Then take them up to the bath, have a nice relaxing bath, then do a baby massage, then have a read of a book, then say your prayers and go to sleep. And, you know, actually, that's a pretty good way but it's a pretty good way for us all to be living, isn't it?
It
And
is.
before
It
we've done our
is.
dinner, we've been out for a walk, you know, and all of those things are setting him up to have a good night. Well, I hope to have a good night. But, you know, we know that those are things that are going to improve sleep architecture. But, you know, and that's how we used to live, like not that long ago. Like when I was at university, which I qualified 10 years ago, I wasn't really in the library late at night with a laptop. I was there with books, like, and highlighters, you know, whereas
Exactly.
now I think, you know, in a very short period of time, everything is online. You know, I'm any postgrad programs I'm doing now, it's all on the computer, you know, even more and more and more. And I would expect, Joe, probably for you're in your career, you probably would have gone from never using a computer to now spending about 50% of your clinical time on the computer writing notes.
I think we all have to be aware, though, that it wouldn't be practical to say to everybody, you can't use your iPad, your child who is all the time on. We just have to limit it as much as we can, get out there and get as much natural bits we can do going on, and
yeah.
give some time period of, as Aoife says, some gap between whatever we do and sleep. You can't, it's not just a light switch you can turn off and then suddenly have no effects. Your body needs to wind, and your mind needs to wind down.
Yep. And I also think just to add to this on the personal side, from doing these podcasts, I've caught my own behaviors. I was 30 years ago, because I'm old, in college, I was that child that was at the library late at night working, but it was with books. So I'm used to being up late and reading before bed, but life happened and technology happened and children. And at some point I got into this horrible habit of, well, let me just unwind by playing some games on my phone until I fall asleep. So, even I have had to backpedal my behavior, and I'm finding, this is, as parents, this is something I think we can do. We're showing our children what to do. So put that phone down, don't pick it up, have a book, maybe sit outside with a cup of tea and talk to your spouse before you go to bed, or something, just change.
And some of us are natural larks and some of us are natural owls. And we do have to acknowledge that as well. But
That's
I mean,
true.
a lot of teenagers would like to start their day later on.
That's how they're programmed.
Yeah.
I wasn't, but apparently other children are.
But it's about actually just acknowledging what's going on. And if you are struggling with your sleep, or your child is, then to actually look at what's going on and seeing what can you do to help and make it a more natural or a more regulated, what's going to increase the likelihood of you having a better night's sleep.
Yeah. Yeah. And I know we've touched on this a little bit, but just to kind of package it up in a nice little way for parents, what are some home things we can do to help our children with not just sleep, but maybe sleep apnea, or what kind of exercises or things should we be doing as they're coming up? I know that baby-led weaning is something that is now being talked about, because we're giving our children all these soft foods, and we're all guilty of it. So letting them chew is good for them. It's going to strengthen the jaw. It's going to help bring it forward. What are some other things that we as parents could be doing to help our children?
Encourage nasal breathing would be one of the ones I'd say. As much as you can, make it a game. Check that they can.
Yeah, because maybe they can't.
To take them to someone who can help them.
Yeah, for sure. So, I mean, from birth, like, breastfeeding if possible, and if desired, then having support for feeding, because we know that tongue tie rates are probably higher than what's, from Brazil, they would say 20% there is tongue tie. So, that's 20% of people who will have issues from the get-go with feeding. So breastfeeding is one, and allergies is the other. Looking at diet and what diet interventions may cause any kind of reflux, and then encouraging, even with the babas, encouraging nasal breathing through oral motor exercises, which would be done with a physio, OT, speech and language therapist, or an IBCLC, or a tongue tie provider, or any of the above together, or an osteopath. There's numerous people that would be involved in that team. And then once they get, as you described, once they start to wean, harder foods ideally, and if possible, continued breastfeeding, because that deep latch, our ancestors would have breastfed till about the age of 4, and we know that was related to having a wider palate, and that's something that obviously is incredibly demanding on the whole family, particularly mum. So the real, how realistic that is questionable in our modern times. but it's certainly baby-led weaning, and really, really looking at reducing allergens where, you know, whether it's dust, dairy, whether it's a dander from animals, you know, anything that might potentially increase any inflammation in the airways is something to be reduced. Looking at maybe increasing filtration for the air, reducing air conditioning. Again, making sure that you're trying to live in an environment that's less toxic. I mean, so much of this stuff is so high and mighty, you know, it really, really is, because, you know, we really have damaged our environment significantly and our way of living in a natural way. But, you know, again, just going back to trying to live as primitively as possible. And then, you know, when a child is getting to kind of 3, I would say would be, I mean, I don't tend to work very well with 3-year-olds, but certainly kind of 4 or 5, you're starting to get a little bit of cooperation, and then doing some core motor exercises. And there are some amazing myofunctional therapists. I think of Barbara Green, she's amazing. She does the most incredible work with like 18-month-olds, and they're doing all of this fabulous myofunctional therapy work and really doing great. But for me, like, you're thinking you're going to get cooperation or sometime 3+, sometimes far higher, and sometimes you got a really cooperative 3-year-old, and I think it's a total lucky dip. I don't think it's, I'm sure there's a bit of parenting involved, but I think sometimes it's a lucky dip. So you just don't know what you're going to get. But yeah, so doing basic exercises, doing breath work, you know, yeah, doing different games to promote nasal breathing, something like putting a lollipop stick between the lips and holding that for 3 minutes so that they're breathing through the nose. You know, they're not allowed to hold that lollipop stick with their teeth. And if you can't breathe through your nose for 3 minutes, that's a direct referral to an ENT. If you can breathe through your nose for 3 minutes, you can breathe through your nose for your whole life. There's a really fabulous book by Patrick McKeown, Close Your Mouth and Save Your Life, or is it just Close Your Mouth and Change Your Life? Yeah, a small little book. And that's a really, really cool little book that you can, you know, it's a pretty simple, simply illustrated book. So, you know, easy enough to start with young ones, but they've got to be compliant. They've got to want to be there, you know, and, you know, and every kid hits that at a different point. Obviously, and unfortunately, or maybe not so obviously, but it's the kids that often need that help the most that are least interested in partaking in that, and that's just an unfortunate reality of how things are right now, and just really difficult for parents who find themselves in that situation, because the last thing you want to do is force a child who doesn't want to do something, because it just for every reaction you got an equal and opposite. For every action you got an equal and opposite reaction, right? So it's just trying to meet them at their level. And then upwards from 7, I think myofunctional therapy is pretty standard. You can do early intervention orthodontics, you know, depending on the patient and the skill of the practitioner. You can start that from kind of 2 or 3 sometimes. I mean, I'm not treating that young. I kind of 4 or 5 would be where I would be like, okay, we can look at doing some, you know, arch development, if that's seemingly necessary. And then yeah, from kind of 7, 8, you've got your window of growth for early orthopedic appliances. And a lot of the facial growth is done around puberty. So I mean, the jaw will still grow. The jaw in a female stops to grow at 18. No, Joe, correct me. Is it the girls are 18, the boys are 21? Yeah, that's what it is. So this continued jaw growth until that point. So you can manipulate growth all the way up until that stage with appliances. And at any point, I think myofunctional therapy is helpful. The thing with myofunctional therapy is you must keep it up. If you work out really hard and you get great strength and then you just let it all, weaken again, then it will probably
You'll go
weaken
back to where
again.
you were.
Yeah, absolutely. And unfortunately, this is why myofunctional therapy doesn't get maybe the respect that it deserves, because it's a constant effort. But similarly, going to the gym is a constant
That's a
effort.
valid
And
point.
if you work out every day for 6 months and then you just don't, you'll look great for a little while and then it'll weaken a little bit.
It's good.
So yeah. But I mean, so the goals of myofunctional therapy is to integrate patterns, neuromuscular patterning, so that you know how to use how to use muscles in the correct way, and you learn to integrate those, but you need to keep up the work.
Right.
And then later, as adults, you've got oral appliances, which Joe's been talking about.
So I'm going to put you both on the spot, and this is strictly just opinion. But from this side of the pond, it appears as though your side is a little ahead of this train, this change that we're seeing as far as airway and sleep and the impacts that it's having, and putting together these diverse teams. So it's not, over here, everything is very siloed. Pediatricians and dentists, everybody's siloed, but it appears that there seems to be a little more cohesion, and you might be a few steps ahead at the moment. So what's driving this?
I'm not sure that's totally the case.
Okay.
Yeah, I would say
that's what it looks like.
Okay. I think the NICE guidelines change, and that's the National Institute of Clinical Excellence. And that's a body that assesses current practice, action plans, and it evaluates the outcomes on results and the benefits cost-wise and to the patient and everything. And they changed in August 21, and they acknowledged oral appliance therapy as an alternative treatment for mild to moderate sleep apnea if they choose not to have CPAP, or if they cannot tolerate CPAP. Now, we all know that CPAP is great if a patient wears it and uses it. But there's many things that make it that the compliance or success aren't as good. And the other options are oral appliance therapy. And it works. And since that has come in, we have now been trying to get that as part of integrated into a treatment option in our health service. And that has been a long process. And we're also trying to now contact, and I think it's more on a personal level. I've contacted the ENT specialists near me. I've contacted the sleep clinics. I get referrals. You asked me earlier how I got patients, and I have been receiving referrals from the sleep clinics for about 10 years, because they knew before the NICE guidelines changed that, if we've got a patient with this and they're not winning, hold on, this works great. And then when I'd sent them back for sleep tests, they'd go, hold on, this works, and they're using it. So although it is slightly less effective per time, in some cases, because a patient tolerates it and complies much better with it, you get equal effect for the mild and moderate. And so really they were surprised when they did post-sleep tests afterwards on the success. They rang me excitedly and said, but it really works. Yes, I know. So I think it's on a personal level, and
Okay.
then it has to drift down, you know, with education, and it's a lot of the medics and
Yeah.
doors of the medical publishers to say, can I put on a webinar to just show you how these group of symptoms could be suggestive of sleep apnea, and that, you know, there's a 2-year waiting list for our sleep clinics. Meanwhile, we could make them an appliance and see if that works, or we could do a home sleep test and this sort of thing. You know, let's try and work more in together. Because if we check if a patient can breathe through their nose, and if they can't, then I refer back to an ENT, you know, to say, hold on, we've got a problem, you know, let's together and try and make. And in some cases, with some adults, when somebody's not been able to comply with CPAP, to wear an appliance with that and have adjunct dual therapy can be extremely successful, because the side effects of a CPAP of high pressure and aerophagia and that horrible feeling of I hate this being full of air, you can have much lower pressures when you open up the airway by wearing an appliance.
Okay.
So that's another option we've got. And so we are trying to make this more multidisciplinary, increase awareness, because we as dentists, patients come to see us, we're in an ideal position. They come every 6 months, we have a look, we chat, listen to them, they trust us. You know, it's that feeling of, oh, do you snore? Yes. Oh God, my wife's not let me in the bedroom. And, you know, for some people that isn't an issue, and other people are, you know, desperate to please help me.
Right.
And it's we're in a great position to see the risks, assess them, and treat them if appropriate.
And it's that multidiscipline approach. That's one of the things that we rally for.
Absolutely.
Because then you're treating them as a whole patient.
Absolutely. And we're looking at their whole health. And we in Britain aren't allowed to diagnose sleep apnea, but we can refer for that. We can do some home sleep testing and get that reported by a physician or a physiologist. You know, we can gain information, and you know, some GPs, medical practitioners are becoming a little more aware, because nobody's been taught this. We're all sort of like new, and we're all fumbling our way through.
Right. As fast as we can. So at the end of every episode, I always like to hand the floor back to our guests and let y'all have the final word. It can be for our parents, it could be for other medical professionals, but just, you know, final thoughts from each of you.
Aoife?
Final thoughts from each of us. Sorry, Joe, go first because
okay. I would say awareness. I want more awareness. I want nasal breathing, more awareness, and go online, rally, find someone who'll help you. Contact us, contact your American Academy of Dental Sleep Medicine. There are people out there. The message is getting out there. We just need to increase awareness on other medics, other specialities, and just keep showing that this can work. And we can really improve people with a little appliance instead of a CPAP or surgery, or, you know, by helping them with myofunctional therapy, we can help them positively change their own health risks.
Without medication.
Yep.
And my thought would be, follow your gut instinct. If you feel as a parent that something is not right, then seek someone who will listen to your concerns, because you're probably right.
Wonderful.
And to professionals, I would say, you want to know what you know, and what we got taught at medical and dental school, half of it's probably outdated. So we got taught anatomy and physiology so that we could understand how the body works. And sometimes we need to go back to that to unpack presentations of what is coming to us in our practices. Yeah.
Yep.
There you go.
Continually learning.
Yeah,
Yep.
absolutely.
I cannot thank you both enough. This has been illuminating and informative and just truly a pleasure. So thank you both.
Thank you.
Podcasts like this do spread the word and increase awareness. So thank you.
Absolutely.